Hi, everyone. Good afternoon. Thank you for coming. Our panel today is titled Emerging Trends in Patient Safety, the Role of New Technologies in Empowered Patients. Patient safety is becoming a recognized scientific discipline, particularly as the U.S. currently faces a healthcare quality crisis despite massive spending. Many institutions have started formal training programs and created quality improvement departments, but patient safety training for physicians remains a relative rarity. We're lucky today to have with us 3 recently trained patient safety fellows from some of the first programs in the area and in the country that are doing this level of didactic and practical training. We also have with us established leaders in quality improvement and patient safety that have dedicated their lives to this. A quick apology, as a couple members of our panel have recently had colds, so there may be a little bit of coughing. Our format today, it's not despite rigorous hand washing protocols. Our format today will, each panelist will give a brief talk on an area of passion for them, and we'll open it up to questions. For those of you at home or in the room, please feel free to tweet your questions to #MedXPatientSafety, and we'll be doing that in the second half of our panel. I'd like to just briefly introduce the people who will be talking today. So Meredith Hurston is a quality assurance technologist at Johns Hopkins. She also runs the blog The Empowered Mocha Patient, which is a healthcare resource for the African American community. Paul Preston does regional patient safety work at Kaiser through Northern California. He's also a practicing anesthesiologist at Kaiser San Francisco. He's now the program director of the Patient Safety and Quality Fellowship at Kaiser, which is entering its 3rd year. Merritt McLean is a OB-GYN, also at Kaiser, who recently finished her Patient Safety and Quality Fellowship and became a certified professional in patient safety through the NPSF, or National Patient Safety Foundation. Alex Dummett is an internist at Kaiser who recently also completed the Patient Safety and Quality Fellowship. He is a co-founder and consultant for Health Fidelity and also a certified patient safety professional. Keith Ruskin is a neuroanesthesiologist out of Yale. In addition to starting a quality improvement fellowship there, he is chair of the board for the Anesthesia Quality Institute, or AQI. And hi, I'm Loren Riskin. I'm an anesthesiologist here at Stanford. I did my training here and then a fellowship in quality improvement, which is a new fellowship for Stanford, recently graduated. And this is what we love. So we'll be talking a bit about the emerging technologies that have gone on, but I think we all agreed that it was important to start where all of healthcare really should start, which is with the patient.
So this is my mom, Mrs. Virginia Hurston, and she is the person that has been the most near and dear to my heart. And she is the reason also that I became a patient advocate. She was a chronically ill patient with type 2 diabetes since I was a young child, for as long as I can remember. If you see textbook diabetic, if you look that up in the dictionary, her picture would be right there. She suffered from temporary blindness, end-stage renal disease, which had her on kidney dialysis. She had vascular disease, heart disease, a plethora of things. And she was a very courageous lady, and as I stand here today, I draw courage from her. In yesterday's closing keynote, Dr. Baron Lerner talked about this whole notion of patient engagement, and while it's not new, it's something that's starting to just gain momentum. So I thought it would be very fitting to share what the ideal process of patient and family engagement might look like. So a patient and their family members need to understand that they are a member of the healthcare team. They're a very valued member of the healthcare team, along with the doctor, the nurses, and the patient care techs, and everyone. And once you establish that you're a member of the team, it's a very good idea for a patient to choose an advocate. And an advocate can be your spouse, it can be your child, it can be your parent, it could be a sibling, but your advocate should be someone that you trust your information, your TMI information, as well as your PHI information with. And both you and the patient and the advocate need to be knowledgeable about what the patient's condition or their conditions are. And you want to ask the doctor, after you're diagnosed with something, you'll want to ask the doctor for credible sources of information. And those credible sources could be an online patient community, local support groups, it could be a blog, a website, or even a book. And you'll also want to be aware of your normal baseline body patterns. That could be your bowel patterns, your vital signs, anything that's key to your particular disease. You want to know what your normal baseline status is, so when you're starting not to feel well, you'll recognize that you're not feeling well. And then once you understand your disease and what your normal is, then you'll want to get involved with your healthcare team. And in order to do that, it's a dignified conversation between the patient, their advocate or their family member, and the provider. And you'll want to talk about your lifestyle. You'll need to know what's important to you in terms of your health values, whether or not you believe in alternative medicine, what your faith is. Your faith can impact your healthcare decisions, what your end of life or palliative care thoughts are. Those are very critical in terms of your treatment, and understand that you have treatment choices. Your treatment choices can impact your quality of life. You'll need to understand the risk and benefits of the treatments that are available to you, and be sure that, and try to decide if those are something that fit into your lifestyle. And also, you'll want to ask questions of all the staff that you come into contact with. Ask questions of your provider, ask questions of your nurse. Anything that you don't understand, speak up, be assertive. No question is a dumb question. And be observant. In order to be involved on the team, you should be observant of your surrounding. That's where patient safety comes into place. Watch to see if the staff members are washing their hands. When someone comes to collect your blood or to draw a sample in the patient office, pay attention. Did they scan your wristband? Did they call you by name? Did they look at your demographics to make sure that you are you and not someone else? So can patient engagement hurt care? I tend to think not. And I came across a quote that really resonated with me on the AHRQ website that says that doctors know a lot about a lot of things, but they don't always know everything about you or what's best for you. So things to keep in mind for patient engagement, as Dr. Lerner talked about yesterday, it's not a new movement, but it's a shift in practice. And with that shift in practice, there's going to be apprehension on both sides, on both the provider and the patient. And for the patient, they want to be confident before they speak with their provider, but it's very good for you to just speak up and ask questions. You don't necessarily have to be confident. No question is a dumb question. If you've done your research, or if you haven't done your research, be sure to just speak up and ask your questions. And on the provider side, the provider wants to feel respected for their expertise, so it needs to be done in a tactful fashion, because this is a learning curve on both sides of the coin. And how might we mitigate harm in terms of patient safety? You can request copies of your paper medical records after each visit. That's a very good idea. You look at those to see if there's any sort of errors in your records. And if they're using electronic health records, be sure to get access to the patient portal. That usually requires a username and password. And you'll want to go in, if you're not very tech savvy, have your health advocate go in and look at your medical record just to make sure that everything matches up with what happened at your patient visit. And when you're in the hospital, you'll want to be knowledgeable about the rapid response team. The rapid response team is in place in most institutions now, I believe. And that's if you go to visit your friend or family member and something just doesn't seem quite right, they don't seem as they were doing as well today as they were doing yesterday, you can actually contact the rapid response team yourself and have them come assess the patient. And this can be an intervention before the patient really starts to decline and perhaps have a heart attack or go into respiratory arrest or whatever the case may be. It's an early intervention. And in terms of medical errors or adverse events, if you have the misfortune of experiencing one of those, be sure to speak up right when you notice that it happened. And Ask if you can participate in the root cause analysis process. They may say no, but it never hurts to ask. And that's where they talk to the patient and the family members to determine exactly what happened, your perspective on what happened. And that can be very valuable information to the healthcare institution. And finally, you'll want to do that without acting litigious. You don't want to say, well, I'm going to sue, and you don't want to bring those words up. Just be very dignified and be willing to participate in the conversation, because after all, you are a valued member of the healthcare team.
Oh, cool. I guess I have to stand up now, don't I? This is a wonderful meeting. I just love being invited here. Thank you so much. I get so many good ideas, and then I have to go home. I work for Kaiser Permanente, and a lot of my job is trying to get us to do common things uncommonly well. And that's really what I want to talk about, because we have some stuff to do in that area, and I really think I wish our patients understood this so they could help us in this journey. So these are pet peeves, and I'll be brief. And I don't know if technology is going to help us or hinder us. Ultimately, I pray that it will help us in this way, if not just to measure where we fall short, but also to actually make it easier to do the right thing. Pet peeve number one. I sat there for half an hour about 2 months ago with my daughter listening on a regional phone call where we talked about documentation of ambulation protocols. It was a rather large conversation. At the end of it, my daughter, who's a college student, looked at me and said, "Was that all about getting people to walk?" Yes. And then write it down? Yes. Well, then why did you, you could have done that in a third of the time. Yes, she was absolutely right. A few years ago, I was an intern, more than a few. Well, I was here. I walked onto my new service day one, and there was a nice gentleman. I got to meet him. He was on his way to the operating room. I said, "I'd like to see you off. I understand you're having an operation today." He says, "Yes, I'm having an orchidectomy." I said, "That's not exactly what he had prostate cancer. He had some metastases to the bone. Technical jargon aside, you do this procedure, which involves castration, basically, to relieve pain, which he wasn't having any of." And I said, "What's involved?" And he says, "I don't know, they had me sign a form." So I told him what was involved. And he got off the bed and left the hospital. So we have a Tower of Babel thing going on. We have a profound failure to communicate. And you know who else has that failure sometimes? Well, have you ever tried to tell your mom how to work a Windows 8 computer? Yeah, we've all been there. Or explain to who it was just what the doctor was trying to tell us. We have a huge problem communicating, and I really want patients to understand that it's not their fault, so that they really are helping us through this particular problem. There are some strategies that I think we need. It's our problem, it's not their problem. But often they end up carrying the burden on this particular one. Ask me three. What are the three things about this particular problem? What's my major problem? What do I need to do about it? Why is it so important that I do this? Should be structured closer for any clinic visit. As an anesthesiologist, the first thing I say after I introduce myself and check with the person who you really are is, in your own words, what exactly are we going to do to you today? I don't want there to be any surprises on that. Tell me what it is that you think you understand. So that's number one. If you don't understand what's going on, let us know. Pet peeve number two. Is there any condition anybody can think of here where it's better to get to it late? Anything? Anything. And yet we set up a whole system of health savings accounts where people are incented to gamble that they're not really that sick. I'm sorry, it's crazy. Now, I work for Kaiser, so I guess I'm a socialist, so you knew I was going to say that. But honestly, it's better to get there early. Get to us early, even if you have to pay a few dollars out of pocket. The next question I ask people if they have a long list of medicines and problems is, how well do you get along with your regular doctor? Which they really raise their eyebrows at. I'm the anesthesiologist. I'm going to knock you out in 15 minutes. And the answer to that is what? Well, your long-term health and survival has a lot more to do with how well you get along with this person and can work with them on these chronic conditions than what I do today, because I can probably get you through it. We're pretty good at that. That's a little bit of confidence building, I suppose. Next one, EMRs are really good at a few things. Boy, they collect data. Boy, they suck me in. When I'm typing on the computer, I am not with you. I'm with your alter whatever, you know, your little homunculus. They really do interesting things to communications and situational awareness. I could tell stories all day about complete loss of situational awareness. And that said, you can't have mind back ever. I love it. It gives us data. Alex is going to talk about that a little bit, that we just never would have otherwise. People need to be sensitive to the fact that sometimes we lose focus because we're playing with the EMR. And other times we know a lot more about them. They need to call us on that thing. And then here's my last one. We're all too busy. We get in a hurry. We do dumb stuff. We have looked at our data. In my region, which is right around you here in Northern California, in our hospitals, infections are half the preventable harm. More or less iatrogenic, but that's what's causing our problems right now. It's not heart attacks, it's not strokes, it's not drug errors. We do all that. Everybody does, but it's infections. And you really need to be empowered, encouraged. Everybody should get a pamphlet when they come in the door. Same way as it says, road construction, slow down, fines doubled. When you come in the door of the hospital, it ought to be, if we didn't wash our hands, if we don't scan your wristband, if you didn't hear us do a timeout before picking up a needle, yell. And here's how you yell, and here's who you talk to. That would be my wish list. Thank you.
So I'm going to talk a little bit about the goals and the history of the patient safety movement. And the essence of the patient safety movement is summarized by this quote by Atul Gawande. The challenge isn't how to keep bad physicians from harming patients, it's how to keep good physicians from harming patients. And we know that good physicians do harm patients. We estimate that between 44 and 98,000 Americans die each year from a medical error, which is the equivalent of the 2 jumbo jets shown here going down each day. The patient safety movement has been gaining momentum over the last couple decades. There was a lot of increased attention in the 1990s. That was when the Institute for Healthcare Improvement, which is a national organization that's done a lot for this movement, was founded. There were congressional hearings, and there was the publication of the seminal document, To Err is Human, by the Institute of Medicine. In the 2000s, momentum kind of continued to grow. Kaiser Permanente has taken steps at national level to improve our systems of care. The Veteran Administration has been sponsoring a fellowship program on patient safety throughout that time period. And other national leaders have continued to focus attention on this movement. Now in the 2010s, we have some exciting kind of joining the mainstream. Atul Gawande, I think, has done a lot as far as bringing mainstream layperson attention to the movement through his essays and his books. We've also had a national conversation around the Affordable Care Act, which has put time, money, and attention on how we can reconstruct our medical system to make it safer, more reliable, and able to change to continue to improve. And then at the graduate medical education level, there's been huge steps forward as far as creating mandates to make sure that our young doctors are learning in an environment that encourages improved safety. The name of the program is the Clinical Learning Environment Review, and the goal of it is to leverage graduate medical education to bring attention to hospital leaders about how well their hospital is recognizing errors and dealing with them. And then, as Loren referenced, we also have increased opportunities beyond graduate medical education and the fellowship level to train young doctors, to train young providers, and then to be credentialed as professionals in this field. So in the hospital level, though, there's different names for this. The essential goal is that every patient, every time, will get the best care, but sometimes we talk about it in different ways. We talk about patient safety, we talk about quality improvement, we talk about performance improvement, and the patient care experience. But each of those are just different ways of emphasizing these 6 main qualities: that the care is safe, that patients will not be harmed by the care intended to help them, that it's effective, that it's based on evidence and produces better outcomes than alternatives, that it's patient-centered, that it's based on the patient's experiences, needs, and preferences, that it's timely, that it provides easy access to care without delays, that it's efficient, that there's no unnecessary waste, and there's no unnecessary procedures or rework, and that it's equitable, that there's a fair distribution of resources based on patients' needs. Speaking to the challenge of effective care, which is a lot of what medical research is focused on, is doing randomized control trials to find out whether or not this drug is better than that drug, which is hugely important and definitely furthers how well we take care of patients. But then it comes to whether or not that patient actually gets the best treatment. And a study in 2003 showed that we're not that good at that. So in a study of 10,000 of American adults, only 55% received recommended care based on evidence-based guidelines. And the goal of the patient safety movement is to make sure that our system is able to provide that evidence-based care reliably. So, and then to personalize it, which Meredith has already done wonderfully, but from my perspective, this is my wife. She's pregnant with our twin babies. And from her perspective, patient safety, and from my perspective, patient safety is that we can trust our doctors, that we can speak up, that we know what our rights are, that we're safe when we're in our doctor's care, that we can access care when we need it, and that it's easy to get the right care. And then from our doctor's perspective, it's that she knows what the best treatment for us is, and she can give it to us, that she can get help from colleagues when necessary, that she can talk to us about what our preferences are, and that it's easy to provide the right care. And then when we walk into the clinic or the hospital, what patient safety means is that all of our labs are followed up on in a timely manner, that all medications are double-checked, that someone is always available in case of emergency, that our medical information is accurate and accessible to everyone who needs to take care of us, and that no one is excluded from the system. Thank you.
All right, can you hear me? So my name is Dummett, and what I'm going to talk about is how are we using technology to foster patient empowerment and safety, and then how will adverse event monitoring help protect patients. So just to kind of project into the future, and the future is kind of now right now, meaningful use stage 3, one of the requirements in 2016 is that improving quality and safety and efficacy, efficiency leading to improved healthcare outcomes. That's a future goal. Kaiser is trying to do that now. So a way to do that is to empower the patients by making sure they have access to the information, access to their doctor, basically at their fingertips. So they have a very widely reviewed and widely, 1 million people already downloaded it. They can email their doctors, check their orders, prescriptions, check their appointments, get active summary, get all the information that they need at their fingertips. And the one application that I was actually a fan of, but I'm not involved with, is Doctella. And Meredith was mentioning the patients ask questions. So sometimes they don't know the right questions to ask. So this is a very interesting tool that's able to pull down specific procedures and either have the physicians push the questions to them to ask when they get to the bedside so they understand it, or they can have like pre-cooked questions, and this is a free application actually. And the main goal is to keep patients from falling through the cracks. So missed opportunities, missed diagnoses, having too little too late of an intervention, delays in diagnosis, unrecognized disease progressions if the patient's deteriorating but it's not really made apparent to the treating team. Misalignment of proposed interventions with the patient wishes. This is the large push in palliative care and identifying patients' wishes beforehand so that when we start going down that path, in Dr. Preston example, they don't have their testicles removed. That was a great example, by the way. I haven't heard that one before. And I've known him for 2 years. God, that's funny. So the project that I worked on for the past year is Advanced Alerts Monitor. And what this is, it's a risk tool. It's identifying at-risk patients in the hospital who come into the floor, not the ICU, and they, while they're in the hospital, actually deteriorate, as opposed to the patients who go right to the ICU, and they also could deteriorate, but often they do a little bit better. So these patients, compared to surgical patients who transfer to the ICU, the mortality rate for the surgical patients is 1 to 3%. For patients admitted directly to the ICU, the mortality is around 10%, 12%. But the patients who get up-transferred, their mortality is much higher, disproportionate harm. So 20 to 40%. They account for about 25%, so a quarter of all hospital admissions. They increase the length of stay by 12%, and their observed to expected mortality ratio is 3 to 4. So visually, what does that mean? These patients, they make about 3% of the population, but they pass away, they die during the hospital stay about 20 to 40% of the time. So this is a very sick population. So what the Division of Research and Gabriel Escobar has done is created a risk tool. There's a lot of risk tools out there, however. A lot of them there's a lot of arguments against them. They're too specific. Some just say, okay, you have risk of diabetes, you have risk of heart disease, you have a risk of heart disease and death in 10 years from this. That's like too little, too late. Or too little, too early, basically. You don't really know when things are happening. So this tool has been created to address a lot of the common complaints to risk tools. So one thing is that it is basically all-cause deterioration. So it's stroke, heart attack, respiratory failure. It's not tuned to one disease. It's every single patient in the hospital gets scanned for their risk of deterioration. Another thing is false positive, false negative. The MUSE or the rapid response team, an argument about the efficacy for those interventions is that they constantly see these patients and see them, but there's been no mortality benefit. And a lot of it's just, they got up to use the bathroom, so their heart rate went up. A rapid response was called. They got back in bed. They did fine. So kind of focusing the response on the patients that actually need it. Also with the code blue, for example, the patient's too far gone. They're basically already deteriorating. They're already in extremis. They're already not breathing at all, basically, and they need to be coded. That can often be predicted. And so what this tool has done is it's been set up so that it fires about 12 hours prior to the patient actually deteriorating. So it uses 62 different factors within the electronic health record. It's all objective data that's pulled in, and it lets the provider know, the rapid response nurse, the physician know that this patient is at significant risk of doing poorly. So it's Kaiser, so we have a lot of data. So the N of this study is actually at 65,000 patients right now. So the N is 10 times more than anything else that's out there right now. It's early and timely, so it's not giving you a 10-year risk, it's not giving you a 10-minute risk, it's giving you a 12-hour risk so you can actually do something about it, and you're not rushing and trying to make up for it. It's not disease specific, so it's not just, that person's going to have a stroke in the next 12 hours. It's any cause of deterioration during that hospital stay is picked up by this signal. And it's embedded in the EHR. There's no calculations. There's no one to have to plug in a whole bunch of numbers. It's just there. It's a number. They cross the threshold. The team is activated. And what I spent my year doing after this was fantastically developed is finding the response that's appropriate for the physicians and the nurses and the palliative care docs and the social workers to actually address these patients early. So what we did is it was a plan for clinicians, nurses including, social workers, by clinicians and for clinicians. We had a year of rapid cycle testings of the workflow using a checklist to use this predictive tool to find, fix, and address the most likely causes of hospital deterioration. And we're implementing it now. So we've been doing it for the past year, since November 19th. It's at 2 hospitals, and we're going to be studying it, publishing it, and going regionally within Kaiser pretty soon, hopefully. It's the safety net. It's catching these patients that would normally fall through the cracks, that our biases would often avoid, and it aids in triage, which patient is the most likely one to deteriorate. And I work at night in the hospital, so this directly impacts me every single day, knowing which one is the sickest, which one I need to see next. It identifies missed opportunities. It provides a safe setting for care goal clarification. And I actually say that's even more important than the work that I do. So saying, hey, who do you want to speak for you in the case that things go wrong or you're not able to speak for yourself? Can you have them come in tonight or tomorrow so we can discuss what you'd want if things continue to deteriorate? And that's a very, very necessary talk to have. And then it improves interdisciplinary communications. Again, I mentioned multiple caregivers. They're all involved in the creation of this tool, so we're not stepping on each other's feet, and we're all communicating with each other with regards to these outcomes that occur. And that's it.
Well, thank you very much. I bring up the rear, which I always do. My name is Keith Ruskin. I'm professor of anesthesiology at Yale University. And before I get started with my talk, I want to amplify something very important that Meredith said at the very beginning, and that's about the rapid response team. And I speak to you not as an anesthesiologist, but as a patient family member. About a year ago, my father was in the hospital, got an inadvertent overdose of narcotics, medication error. None of the nurses on the floor would believe me that something was wrong with my father. And I tell people I don't know much, but as an anesthesiologist, I know breathing. I watched him stop breathing. I picked up the phone myself as a family member and called the rapid response team. They saved his life. So please use the rapid response team. The one message you take home today. So what I'm going to be talking about with my other hat on is looking at large databases. So now we've gone from patient empowerment, giving you as patients the tools we need to make you better, to giving doctors the tools to see how well patients do overall. And one of the interesting things about the electronic health record is that it gives you access to a single patient's data, but it also gives you access to thousands of patients' data. And what that gives us is the ability to answer a fundamental question: what do we really do to our patients? I always tell people as an anesthesiologist, if at the end of the case the patient is awake and breathing and isn't vomiting, great, I did a great job. But it turns out that things we do in the operating room may have an effect a year or more later. And this is one of the studies that got me interested in this. It's a study, it's old now, published 6 years ago. And these people looked at people who received a transfusion after a hip fracture, something we do all the time. Patient comes in, they broke their hip, they've been bleeding into the joint, the hemoglobin level is a little low. I'm going to give a unit or two of blood, make them feel better. Sounds like a good thing to do, doesn't it? Here's the problem with it. The transfused group was more likely to die, and that association didn't begin until 90 days after surgery. So here I'm doing something that makes me feel good in the operating room, makes the patient feel good in the operating room. 6 months or a year later, that patient's dead. Maybe my transfusion had something to do with it. So this is the kind of thing that we can look at. And what I'm going to talk a little bit about is electronic health records and big data. I'm chair of the board of the Anesthesia Quality Institute. We've got a very large patient database. Now we've got over 20 million individual anesthetic records, 4 million of which have complete patient data with outcomes, and this is only over the past 5 years. As of this year, we're capturing almost 30% of anesthetics in the United States. We've got a clinical outcomes register. We've also got an adverse event reporting system. So people can report things that happen in their institution to a national database so we can start to look at this. And we're finding some very interesting things that I'll talk about in a couple of minutes. By the way, quality is also important because it was Talib Kweli's first album when he came out as a rapper about 8 years ago. Very important point. So what do you have to do in order to make things better in a hospital? And it turns out a lot of people have looked at this. The first thing you have to do is figure out what it is that we're doing right and what it is that we're doing wrong. How are we affecting the quality of care that our patients get? Once you do that, the next thing you have to do is you have to figure out how to measure that. How many people are doing the right thing? Does doing the right thing really make a difference? How much does doing the wrong thing hurt? Why are people doing the wrong thing? Here's where it gets hard. Now you've got to create interventions, and a lot of those interventions are based on social science. You've got human interactions, so you've got to get thought leaders. But most important, and I always tell people, education is good, but engineering trumps education. You've got to create systems that enable people to do the right thing and hopefully discourage them from doing the wrong thing. So you've got to develop new equipment, new procedures, techniques for medical decision-making like what Alan was just talking about, early warning systems. Lastly, you've got to take all these things and not use them in isolation, but put them together as part of a coherent package that's going to improve patient care. So the Anesthesia Quality Institute, as I mentioned, individual cases from individual practices, and we get whatever you will send us. Initially, we were just taking demographics, billing data, procedures, things like that. Now we're insisting on the complete anesthesia record, and electronic health records make that easier than ever. And a lot of the reporting is available online. The idea, better local outcomes for people in their individual practices, better national outcomes nationwide. We're starting to work with some practices in some other countries, so who knows, maybe one day better global outcomes. Just to show you a couple of slides about what the practice gets, and this is a little hard to see, but we can actually give individual groups feedback on how they're doing. So a lot of this data, a lot of these graphs are sort of blanked out, so you can't see who it is, but we're getting individual data on a given number of cases from a practice. Here's where it gets interesting. We can give you information on how many of your patients had untreated post-op pain afterwards based upon what was in the nursing notes. How many of your patients had post-operative nausea and vomiting? How many of your patients had a major complication like a stroke or a heart attack, maybe 2 or 3 days out after you're no longer caring for them? This is the kind of information that we can give you. The other thing that I think is an equally powerful tool is the anesthesia incident reporting system. Now, this is for near misses. And one of the nice things we did with this is we got this created as something called a patient safety organization. That's a legal term, but what it means is that cases that are submitted to us are protected from use in medical malpractice suits. So people are more encouraged to report, and they're encouraged to be honest. You can report confidentially where we know who you are, so we can contact you and get additional information or a follow-up if we want to. But if you don't want to do that, people can report to us completely anonymously. And it's very interesting because we don't even track IP addresses. When you report anonymously, we discard the IP addresses from the log, so we don't even know the internet address of the computer you used. It takes about 5 minutes to enter a report. I've entered a number of them myself, not because I have tons of bad outcomes, but because I encourage people to do it. And where this goes right now, the immediate output is we have monthly case discussions that are available online on the website and also are published in the American Society of Anesthesiologists newsletter. The other thing we do with this is we're starting to do research. We've got a guy who's developing some natural language queries. We're doing some statistics on this. And what we're finding out is something that may only happen to me once happens to a lot of people once. So things that we thought were very rare are in fact common, but don't happen to individual people that often. A lot of very interesting data. So what are we going to do with this? We're starting to pick up on some of these large-scale, long-term trends like transfusion, like stroke after surgery. We want to use these for research, obviously. We want to improve it for quality improvement. But we also want to use it for education. I like to tell people that most of what I learned in medical school is wrong now. Hopefully we can find out that it's wrong before I finish medical school rather than 20 years later. We can learn why critical events happen. We can start to do more research around taking care of these critical events and treating them when they do happen. And ultimately where that leads to is better patient care. Now, as we were standing outside before we came in here this afternoon, we were talking, and I said, the way I know if I gave a good talk or not is if nobody leaves, nobody throws anything, and I didn't get arrested. I think it's a good talk, and I hope that I don't get arrested when I walk out of here. Thank you very much.
Thank you all. I'd like to open it up if anyone has any questions. There are some standing mics and some hands going up. Yes.
Hi. So I have arthritis, and I'm part of the arthritis community online and so forth. Autoimmune arthritis, I'll specify that. I know a parent of a child with JRA who is a patient at Kaiser. They've been there for a very long time. This child recently turned 12 years old, and her records were closed off to her parents because she is 12 now, and it was chosen that this was safer for her. She now has the responsibility as a 12-year-old of looking at her labs, of scheduling her appointments. And, we're talking about all of this technology with patients and so forth, and I'm wondering, when it trickles down like that and you're looking at a family that's dealing with a chronically ill child, how are they to manage their care and the psychological effects of helping her grow up with a chronic disease like that when the technology is not working for her?
Great question. I can't look at my own daughter's medical records, but actually I can if she is willing to say, hey, you can have a look at my records. So there is a paperwork bit which allows people to re-access. Now, it may not be a perfectly developed functionality there. And again, you have the conflict of, well, how do you preserve confidentiality for a particular individual versus the shared mental model of how the whole family is going to manage a chronic illness? I'm not sure anybody's got the perfect answer to that one. I am pretty sure that there is a way to work around that, and I'd be happy to talk offline because I know they send us as physicians. We can go into any chart in the world, and we can get fired for it too. So they tell us, okay, you better really have permission, and this is what it looks like. And then actually a lot of these records are in fact open to you.
My name is Erin. Twitter hashtag is Erin is the Mesh Warrior. I think I should change that to the person who asks questions in every panel. But I have a lot of questions. I'm going to try to make it quick. I love anesthesiologists. They always have the best personalities. So I love that you guys are all trained in that way. This question is the most important to me, so I think I'll go with this one, and is for Dr. McLean. Since you're an OBGYN, you may be familiar with the recent very large adverse event reporting regarding polypropylene mesh and its use in obstetrics. You talked about in your presentation, you had, healthcare goals or this is what we're shooting for. And the first one was that good doctors don't harm patients. I assume you're a really good doctor. And because I assume the best about everybody. But the massive scale of the nature of this preventable harm, and it's massive in the very multi-millions. And of course, this device is still on the market. I want to address the 510K process, the dirty little phrase that I don't think I was supposed to say, but I did. Because good doctors harmed patients because in large part of that process, and having had no tier 1 ethics, double-blind studies long-term to present to the doctor who can then be the learned intermediary and inform the patient. How are you addressing that in patient safety, the 510K process?
I think that's a great question, and one that obviously is going to be hard to fix because it's kind of a national...
Impossible to fix.
Yeah, I mean, what you're talking about is that we have different standards for medical devices than we have for medicines. And so it's very easy to bring a device to market and to market it to physicians and to have them use it without the same sort of rigorous scientific inquiry that would happen in sort of for a medication. And I think that there are different ways to address that. I think it's going to be hard to solve kind of the core FDA issue. But I think as far as kind of at our level, the things that we can do are as much as, taking money out of physicians, or not taking money out of physicians, but as much as possible, not having pharmaceuticals directly advertising to physicians. Kaiser is farm-free, and so I think that we have a good model as far as that in order to use anything in our hospitals, it has to go through a regional process to get approval for it. So there's a little bit less like, I just talked to this marketer, and he really sold me on how pretty and soft this mesh is, and now I'm going to use it. So there is less of that within our system. I think that the flip side to that is sometimes we're slow moving as far as adopting new technology, but I do think that balances in that I think that sometimes being slow moving is good because then you don't as quickly get yourself into a scenario where everyone's suddenly using this new fancy thing, and then 6 months later it turns out there's huge complications from the new fancy thing, and tons of women have been affected by it. I think you bring up a great point. That's definitely a huge issue in our country in a variety of different scenarios. But I think that the model of it, of having kind of large groups of, large scale systems in place, like Kaiser, like Mayo, like other sort of Intermountain Health, where the entire organization is being thoughtful about what is being used there and making sure that there's good safety evidence for it, and that it actually is more cost-effective and better for patients than the alternatives.
And I know that Kaiser is a leader in that area. Were you taught about that process and how to deal with the reality of that process in your patient safety fellowship?
That's a good point. Here's the director here. Yeah, we should talk about that more.
I think so.
I mean, it came up as part of my residency training. It's certainly something that we talked about. I think in particular in gynecology, the mesh example is kind of a one that obviously is something that we talk about. I've never used mesh, so
Thank you.
That's by the time I trained, that had already we had realized the complications of it. Yes, I think it's something that we as individual physicians should be looking at and thinking about.
And maybe adding to the curriculum of a
Yeah.
patient safety fellowship.
Yeah.
One more question. Do you think that a patient safety advocate has to have the credentials of an MD and a fellowship in patient safety? And if the answer is no, I see you're shaking your head. If the answer is no, then what, in your opinion, would be a respected, degreed, certified patient advocate that in the care team would be respected as much as all of the other care members? Would that be a BA, an associate's degree, a certificate, what?
So I would love to field that one in our
Yeah.
last couple of minutes here. No degree required. I think that everybody on this panel will nod in agreement with me while it is wonderful that we now have specialty trained, fellowship trained MDs to work within the hospitals, when it comes to your individual care, your family, your loved ones, you do not need a degree. You need to be there or to care or to hold their hand or support them. And it's our job as physicians to listen to you regardless of whether or not there are letters after your name. Showing up, being present is really all that should be required. There's a gradual shift happening, and it's more gradual than we'd like, towards involving patients, family members, and loved ones in the care team. But while training is lovely and there are wonderful resources for anyone interested, the Institute for Healthcare Improvement has an open school with wonderful modules available to anybody who's interested in more formal training. You don't need it. You just need to speak up. Tell us if we're doing something you don't like. Tell us if there's something that you think that you need that we're not doing for you. And help us help you. And physicians over time are becoming more and more invested in you being a crucial part of that healthcare team.
I would say the way that you could help us is, I've seen this a lot with my mother, who is bedridden and has lifelong, profound, life-altering injuries from the mesh. And I have seen my mother, who graduated at the top of her class as an RN, be intimidated by education and intimidated by doctors, and because she didn't have the letters after her name, even though she's brilliant, but she's sick.
I'm sorry to hear that, and perhaps we could talk more offline. If we have time for one more question.
I'll be brief, sorry. So Meredith mentioned that the patient is, a very important part, potentially the most important part of the healthcare team. The one thing I didn't hear in any of these presentations, and granted that might not necessarily been the subject of it, was health literacy. If the patient's supposed to be really important, how do we raise that boat to make sure that we know what we need to ask? We need to know what you should be doing, what you're not doing properly. I understand that there are protocols and procedures that might be above my head for you guys to analyze, but if I don't know what I don't know, then we're all going to have a big problem here. So how do we fix that problem?
So I think Alex and Meredith probably, Alex mentioned, he'll talk in a moment, Meredith actually runs a blog if you'd like to talk about the empowered MoCA patient, or Alex, if you'd like to talk more about Doctella and some of the other resources.
Yeah,
It's a great
there's
question.
stuff out there. There's a lot of stuff out there. But
Well, I mean,
definitely
I
hurts.
might know that, but I'm here at Medicine X. I've got my MacBook Air and, all my high-tech stuff. But for the people that are seeking that care, that don't know that stuff, how do we help them? I mean, I guess we just say the underserved patient. How do we fix that health literacy problem?
I think that's where we have to rely on community outreach workers, people in the community, social workers. I don't want to put all the burden on them, but volunteers. Someone has to get the word out for people that aren't tech savvy or online, but there's a wealth of information that's online. But I've seen pamphlets. I recently visited a facility in Virginia, and they had the equivalent of the Joint Commission Speak Up campaign in a pamphlet, and it was very helpful. It was very thorough. It was very helpful talking to the patient about questions that they could ask during their visit. But I think it's just kind of like word of mouth, and If you are tech savvy and aware and can research the information online, share that with your family members, share that with your friends.
I think there are also simple things that institutions can do. So our hospital has a campaign now for hand washing, and on the there are signs in front of the patient's bed where the patient and family member can see it. Did your healthcare provider wash their hands? Ask your healthcare provider if they've washed their hands. And that simple thing, you see that happen. I come into a room, did you wash your hands? Oh, yes, I did, right outside. If not, there's a Purell thing right under it. So I think there are things that institutions can do. And there are also a lot of individual organizations for people with chronic disease that are very powerful. The arthritis groups, for instance, are fantastic. There are diabetes groups. There are all these foundations that can help people get the information. But you're right, the problem is letting people know that it's out there.
And one more big data solution, which actually is one of the most exciting things I see. When we fail to communicate effectively, people don't take their pills. And we find their blood pressure, their diabetes, and their cholesterol are not controlled. We measure that. We actually incent our physicians to get on top of it. And that's a really interesting signal that whatever conversation you had, it didn't work for the person it actually matters for. We need to start to harness and hold ourselves accountable for making those measurements and those interventions.
All right. Thank you all very much. Have a wonderful rest of your Saturday, and I think we're going to hand it over to the next panel discussion.